we continue our work of hearing about walking in our shoes. And I have truly enjoyed our speakers that we've brought in. It's been wonderful, and we've learned much from them. And I'm very happy to introduce my sister, Jean Haspel. Jean is a nurse practitioner, and Jean has been my hero my whole life. And truly, Jean is my oldest, older sister, not my oldest. And we're 2 years apart, and
21 months.
Okay. I knew she was going to say that. And but just we grew up together as best friends and sisters. And my sister Jean went into nursing. She's going to tell you her story. She is going to tell you about the people who have set her story in place. And Jean is amazing. It's been my life dream to work with Jean and the ministry that she does in this world. And I'm so glad you're going to listen to her story and listen to the people that have touched her life. Jean, oh, that's your water.
Yeah. Good morning.
Good morning.
It's very good to be here today. So I'm going to tell you about my story, how it got started, and kind of where I am today. I graduated from the local community college in Atlantic County, New Jersey in May of 1986 with my associate's degree of science in nursing. I was 24 years old at the time. I'd been working at the Sands Casino, and I dare not give up my full-time job until I passed my RN boards, which I took July of that year. My results finally came in the mail in October, and to my surprise, I passed them on my first attempt. I immediately set up interviews with both of the local hospitals in Atlantic County. I was offered a position at both, but I decided to go with the Atlantic City Medical Center in Atlantic City. I had no idea at the time that I had just made the best decision of my life. I started working at the Atlantic City Medical Center on November 3rd of 1986. It's hard to believe that I'm in my 40th year of nursing. I was hired for a medical surgical gerontological floor. The floor consisted of 22 rooms, and our full census was 36 patients. I trained on the day shift, as all new nurses do, for about 6 weeks. And then I went to my assigned shift, which was 4 p.m. to midnight. It is generally a less busy shift, consisting mostly of intravenous medication and intravenous fluids, dispensing of oral medications, serving them dinner, getting people ready for bed, and of course, charting. While I loved the hours, I knew if I stayed on this shift, I would probably never leave it, and I would never get recognized. Only day shift nurses got any recognition at that time. So after 2 years, I decided to go to the day shift. Probably the second best decision of my life. While most of the patients admitted to the floor were either medical surgical in nature or of gerontological age, we started to see a whole new type of patient. We were getting more men, both young and old, diagnosed with a relatively new disease known as AIDS, acquired immune deficiency syndrome, caused by advanced HIV infection. The majority of HIV/AIDS patients at that time were persons with a history of injection drug use, or they were homosexual. HIV in 1989. I was now seeing young patients my age, or very close to my age, with an infection that was incurable. And in 2025, it's still incurable. I became consumed with the AIDS patients. A very dear friend of mine from school, his name was Tom. He was a homosexual. We met in our art class in our junior year. Tom was a very strong and muscular young man, as he was a gymnast. He was involved with the local Methodist church in their youth group and sang in their choir. Students in high school would talk about him behind his back, about his sexual preference. But due to his size, no one would dare take him on. He was very charming, and we became good friends. We even attended our senior prom together. So seeing these young men on the floor, mostly homosexuals, who were very ill and many died on our floor, I could not help but think about Tom and wonder what was going on in his life. And just as I became Tom's friend in high school, I became close to the AIDS patients on my floor. You have to understand that frequent and recurrent hospitalization was common at that time. Patients would develop pneumocystis pneumonia, also known as AIDS pneumonia, and at the time it was the leading cause of death. We didn't have good treatment for it. We didn't know how to prevent it from happening. Frequent episodes of the PCP pneumonia could cause lung collapse, which is a medical emergency. Insertion of chest tubes was the treatment, and often performed at the bedside by the cardiothoracic surgeon and the floor nurse. The damaged lung would reinflate, and administration of intravenous antibiotics and other medications would follow for many days. Another reason for hospitalization was in AIDS patients was Kaposi sarcoma, a non-fatal cancer usually seen in older men of Mediterranean descent. However, in the AIDS patient, bluish purple lesions began to appear on the skin, initially taking the appearance of bruises. They would darken over time and continue to grow. In some cases, the patient's skin would be covered with it, including the nose, skin, and toes. You may remember seeing the movie Philadelphia, and the main character, played by Tom Hanks, developed facial Kaposi sarcoma on his forehead, and the law firm found out about his diagnosis and fired him. Not uncommon at that time. Again, the Kaposi sarcoma skin lesions were visible in the skin, but they also developed cancerous lesions inside their body and on their organs. I don't mean to upset anyone, but the smell of the lesions was pretty atrocious. It was rotting skin. While oncologists tried to give them chemotherapy to treat them, these patients expired rather quickly due to the already weakened immune status. I'd like to tell you about Matthew. Matthew was a petite gentleman with a great tan and even better hair. I soon learned that he was a bit of a celebrity in Atlantic City, having frequented the gay bars. He had a lot of friends, he had a lot of visitors. I remember going into his patient room to introduce myself. I sat on the edge of the bed. I was not wearing any protective equipment at the time. I was not at risk for acquiring HIV from him. And he was not on any kind of specific isolation precautions. We talked for some time and he stated, "You should go work in that AIDS clinic next door." I knew that there had been a clinic at the hospital because our hospital had a medical residency program. I did not know they had a specific clinic just for AIDS patients. It's really called the Infectious Disease Clinic. But Matthew informed me that he had encountered nurses in the hospital and on other floors who didn't want to come into his room, did not want to bring him his medication, and did not want to care for him, let alone sit on his bed. Dietary staff were afraid to deliver his food to his room. We nurses would often have to take the food into our patients. My heart ached for him at the time, and I wish I could take away the feelings that he had and his pain. I learned from many other of my patients that they had experienced the same type of stigma in their lives. Again, my heart just sank. I could immediately empathize with him and with all of my patients. It was not a very comfortable place to be. By 1990, our floor, 5 East, at the Atlantic City Medical Center, was the designated AIDS floor. This occurred because our patients, arriving in the emergency room, knowing they need to be admitted to the hospital, said, "I want to go to 5 East. These nurses know how to take care of me." Our clinical manager made sure that every nurse who worked on our floor or who was pulled there wanted to be there. We didn't want nurses be there who were going to stigmatize our patients. And we received additional training on HIV and AIDS. Another patient I'd like to mention, his name is Jimmy. Jimmy was an AIDS patient being treated for endocarditis, an infection of the heart muscle, caused by his history of injection drug use. In 1990, this diagnosis of endocarditis meant that patients were hospitalized for a minimum of 6 consecutive weeks because they needed intravenous antibiotics every 6 hours. We didn't have the long-acting antibiotics that we have today. Jimmy was Italian, he was handsome, bit of a hardcore guy, but a people person. And he was lonely. He didn't have any local family or friends. And while he was hospitalized, he was given methadone to manage his opiate addiction. He was not allowed to leave the hospital. Few patients are. So he quickly made friends of the nurses. Remember, nursing at that time, majority of nurses worked 5 days a week with 2 alternating days off. And the turnover of patients is nothing like it is now. You get hospitalized now, you're there a couple of days, you're out the door. Patients were there for a long time, for days and weeks. He would sit with us at the nurse's station and tell us stories about his life when we were sitting and charting. He was from Philadelphia, started to use heroin at a young age, and recently found himself living in Atlantic City. He would occasionally ask a nurse to bring him something he could not get at the hospital, like a pack of cigarettes. Yes, people smoked on the floor back then, or maybe a tasty cake. He was special to all of us. And when he was discharged, he was really missed by all the staff. Caring for any patient for 6 straight weeks on one floor can leave an impression on you. The patients on 5 East lived and died with us. Very few family members could or would take them home. There was no nursing home that would take them due to the diagnosis and the fear. Only a few patients with good insurance coverage and family were accepted into hospice care maybe in their parents' home. The longest hospitalization we had with one patient was with a Latino man. He had AIDS and dementia and was with us for 9 months until he passed. Moving ahead a couple of years, I'm working on the day shift. It was at this time I got to meet the infectious disease physicians from the clinic. They would round on the floor, the advanced practice nurse, the social worker. They would come and see the patients after clinic days to see how they were doing during their admissions. They would ask us nurses for feedback about how the patients were doing. Little did I realize that they were watching us and the care we provided. I was asked by this clinic to help facilitate direct admissions from the clinic to 5 East every Tuesday and Thursday morning, as they were the clinic days. The clinic would see about 40 patients each of these mornings. We had 2 infectious disease physicians, we had medical residents. Clinic could run from 8 a.m. till 2. Many times they didn't get lunch. But patients would come in very ill and would be sick. So I would write the admission orders under the guidance of the infectious disease physicians and literally transport the patient to the floor. We could bypass hospital registration. We could bypass the emergency room. And I would get them to their room and get them settled, give report to the nurse. So it was just streamlined admission. Very unusual at the time. Then an offer I could not refuse came my way. The infectious disease clinic was going to start offering patients AIDS clinical trials in Atlantic City. The infectious disease physicians and practitioners wanted me to join them. Out of all the nurses on my floor, they chose me. I was floored, and of course I said yes. So off I go to the infectious disease clinic as the research coordinator for AIDS clinical trials. We were a satellite site for the North Jersey Community Research Initiative in Newark, New Jersey, still in existence to this day. The next thing I know, I'm flying off for nationwide training on how to be a research nurse. I'm also attending meetings quarterly in Washington, D.C., sitting with leading experts on HIV around the United States. I had so much to learn. In May 1993, I completed my bachelor's degree in nursing at the local state college in Pomona. And I was looking forward to some time off from studying. I had been in school for quite some time. But the nurse practitioner I worked with, Patricia Lim, handed me an application for the University of Pennsylvania and told me to fill it out. She was a graduate of the program herself. So I asked her, how am I going to pay for this? She said, don't worry about it, just get accepted. Little did I know that she was writing a proposal to the head of the hospital, recommending an advanced nurse practitioner fellowship. Patricia was tired of seeing nurses getting business degrees and leaving the bedside, leaving nursing and becoming administrators. She always said, we need to keep nurses in nursing. I started my education at the University of Penn as a non-matriculated student in the fall of 1993, taking one class. In the spring of 1994, I took a second. And that summer, I was accepted into the University of Penn's Adult Nurse Practitioner program. And I was one of the two first recipients of the Advanced Practice Nurse Fellowship. I graduated in August of 1995 and began my career as a nurse practitioner with the infectious disease clinic. Not only did I see patients in the clinic and round on the hospital floors, but I also had about 40 homebound AIDS patients who were too sick, too ill to come to clinic. To bring them to clinic meant we had to call an ambulance. They had to be brought in via stretcher. And it was just a lot to pull some of these patients in from their home. So I would actually go to their home and do house calls, prescribe their medication, even draw their blood. I'm very good at drawing blood. But due to the advent of a highly active antiretroviral therapy, which began in 1994, combination therapy, putting at least 3 HIV medicines together, within a year, there was no longer a need to do house calls, as the majority of these patients were no longer severely debilitated and they could return on foot to the ID clinic. I'd like to talk about the next chapter of my life, how I got involved in treating, additionally, patients with HIV, but also patients now with hepatitis C. So I'm in the infectious disease clinic, and our patients are living due to highly active antiretroviral therapy. Deaths from HIV-related causes have decreased. But at this time, we're seeing increased complications and deaths in our patients who are co-infected with hepatitis C. Currently, our patients have the option of being treated in the gastroenterology clinic in our building, or if they have insurance, they could see a private gastroenterologist, they're all located off the island of Atlantic City. So you have to have transportation to get there. So I'd like to tell you about Paul. Paul had been one of our HIV patients for many years. Since he was diagnosed with HIV and he also had hepatitis C infection, I recommended that he start treating his hepatitis C at the GI clinic. I've seen some of our patients develop cirrhosis, end-stage liver disease, and liver cancer. So it's very sad to see someone surviving HIV but dying from hepatitis C. So Paul began treatment with injectable interferon 3 times a week, and he was taking pills twice a day, ribavirin. So at the time, the treatment was a minimum of 9 months, and the side effects were very similar to actual cancer chemotherapy. I learned that Paul had a stroke, a cerebral vascular accident, caused by anemia related to his hepatitis C treatment. His hemoglobin dropped very low while on treatment, and the gastroenterologist, who were only in the clinic 2 days a month, missed his laboratory finding. He should have received transfusions. I must admit that I was saddened to learn the news, having been the one to recommend Paul have this treatment. Paul's stroke symptoms included hemiplegia, which is, weakness on one side of your body, and aphasia, the inability to talk. He returned to the ID clinic in a wheelchair, accompanied by his wife. I was in tears. Tears of joy to see him again, and tears of regret that I had recommended this treatment. Luckily, Paul did clear the infection, and over time, the stroke symptoms improved so that he could walk again, use a cane, and he regained his speech. Then, our gastroenterologist at our GI clinic decided to abandon the clinic. That meant no more GI referrals at the clinic for all the clinic patients, no colonoscopies, no hepatitis C treatment. And I decided that was not acceptable. So I went to my colleague, Joe, a nurse practitioner like me, and I said to him that we need to take over treating hepatitis C. We had too many patients co-infected with hepatitis C that are living with HIV. And we only had to learn 2 medications. I'm trying to convince him to join me. The medications were interferon and ribavirin. Luckily, Joe and I were very similar in our love for our population. Joe had been a Catholic priest, and he's a family nurse practitioner. He left the Catholic Church because he was homosexual. He became a missionary and went to Bolivia and worked there for 10 years. During that time, he provided advanced nursing care to the residents of Bolivia. He birthed babies and at times performed minor but life-saving procedures on the local residents. And he was fluent in Spanish when he came out. We built a wonderful friendship that persists to this day. He has since retired, and he and his partner now reside in Florida. So the rest is history. The infectious disease has began treating hepatitis B, hepatitis C in the early 2000s. The numbers of patients dying from either diagnosis plummeted. I cannot say that we saved them all, but we prevented the majority of our patients from dying from cirrhosis, end-stage liver disease, and liver cancer. Hepatitis C treatment in the 2000s was very tough. I mentioned the interferon and ribavirin, and only had a cure rate of about 40%. But when Joe and I took over the treatment, cure rates varied between 60 and 80%. Due to the frequent visits with our patients, our frequent monitoring of labs. The work was labor intensive. There was a lot of hand-holding with these patients. But the satisfaction of telling them that they've been cured of hepatitis C was priceless. I continue to treat hepatitis C to this day. Treatment is now all oral medication. It can be 8 weeks or 12 weeks, depending on which one the patient chooses. Side effects are minimal, and now 98% of patients are cured. Treatment of opiate use disorder has been available since the approval of methadone in 1972, but is only available at state-sanctioned opiate treatment programs. In Atlantic City, we've had a program for as long as I can remember. It's changed its name. First it was called NARCO, then the Institute for Human Development, and most recently is the John Brooks Recovery Center. John Brooks Recovery Center is now part of Atlantic Care. For my HIV patients who are using heroin, there was no treatment at that time that I could offer them, except assistance getting into the opiate treatment program. Many patients who start methadone remain on it for life. I've not seen many patients who were successfully weaned off of methadone and remain drug-free. It is not without short-term side effects, such as constipation, and long-term side effects in men, such as hypogonadism, which is lowering of testosterone. In my HIV co-infected patients, avascular necrosis is common. It is when a joint, like the head of the femur or shoulder, the blood supply stops flowing, and that part of that bone dies off. It becomes necrotic, and it causes a great deal of pain, either hip or shoulder. In the early 2000s, a new drug came to the market called Suboxone. It's a combination of buprenorphine and naloxone. It is prescribed by physicians and self-administered by the patient sublingually. Of course, I was very interested in this. Something new, something to offer my patients. However, the infectious disease physician that I was working with really wanted no parts of this. He did not want to treat patients. I could not prescribe it. At the time, it was only physicians could prescribe it. So my hands were tied. At the time, physicians had to obtain special training in order to prescribe it, and it was not available to advanced practice providers. Luckily, in 2016, the law changed, and advanced practice nurses and physician assistants were allowed to obtain a special training and additional DEA waiver, known as an X waiver. So after 24 hours of online training and subsequent testing, I obtained my X waiver. The first year, APNs are limited to 25 patients. Year 2, 100 patients. And in the third year, 275 patients, which is a great number of patients. So I want to bring it all together and talk about the synchronized epidemic that we have in this country: HIV, hepatitis C, substance use. You see, it all goes together, and I could see this from the very beginning. So in 2017, my prayers were answered, and I began treating patients with substance use disorder, both opiate use disorder and alcohol use disorder. But I'll be only discussing right now my experience with opiate use disorder. When you first meet a patient with an opiate use disorder, you perform a substance use history. The very first questions are, how old were you when you started to use opiates? What opiates have you used? How did you use them? Did you swallow the pills? Did you crush them? Did you sniff them? Did you inject them? Skin popping, you ask. What are the circumstances? Many patients admit to buying pills on the street, which was very common up until about 10 years ago. We all know that we have lived through an epidemic of opiate use disorder, much of it caused by practitioners even like myself, who have treated patients for pain, and we're told, suddenly pain is the 5th vital sign, and you must treat their pain, because it affected the scores that we received, patient scores, and it was about patient scores. So I carry around some guilt, having been part of that era, in medicine, but luckily that, for the past 10 years, we've gotten away from prescribing, and we have patients see pain management providers, and we have other mechanisms to manage pain. But our patients, at the time they were buying the pills on the street, they could be very expensive. Oxycodone, a short-acting medication, OxyContin, a long-acting medication, morphine, Vicodin, all kinds of Dorgesic patches. These things were on the street, but they became very expensive. So many patients switched to heroin, which was much more reasonable to do. Some patients told me that they had had some surgery, and after surgery they were prescribed some pain medication. But then they really started to like the way it made them feel. And when the prescriptions stopped coming, they started buying pills on the street. They started using heroin. Some patients had dental work. They were prescribed pain pills. You might notice your dentist is not so free-coming now with the prescriptions for pain, right? Because that's all it takes, one time at a dentist. Some patients said it was peer pressures. My friends were doing it. I want to be like my friends. Some patients told me it was one or both of their parents who introduced them to opiates. So no matter the circumstances, he or she is sitting in an office with you, they're looking for help. They're ready to get off that roller coaster of opiate addiction, and they're asking for treatment. Most patients come in having recently used an opiate, probably within like the last 8 hours. Currently, we offer them comfort measure medications, something for nausea, anxiety, diarrhea, muscle pain. And we ask them to abstain from using any more substances, opiates, for the next 12 to 24 hours. Most time we ask them to come back if you can. And we'd like to get you started the next day. Some patients are at a point that we can actually prescribe them some Suboxone to take home, like 1 dose. Take this home by prescription, start it, come back tomorrow, so we can, start from there. The thing is, because Suboxone is a combination medication of buprenorphine and naloxone, the naloxone is a blocker. And if you're already using heroin and you put this in your body, it's going to put you into a very ugly withdrawal state very quickly. So we call it precipitated withdrawal. We don't want this to happen. I've only had it happen once to me in the office, in this substance use disorder clinic. And when it does, we do offer the patient a ride to the emergency room. We call an ambulance, we have to take them to the emergency room, where they're given more supportive care than we can provide. We're an outpatient treatment program. We work Monday through Friday, 8 a.m. to 4 p.m. And we're limited to the level of care we can provide. So again, each practitioner performs an assessment on the patient so that we can determine the best level of care for that patient. Would the patient really benefit from an inpatient treatment program? If so, we will connect them with one that day. We will help them get transportation to that treatment center. Our patients naive to treatment may be asked to return daily, Monday through Friday, so that we can dose them in the office and we can do an assessment and see how they're doing with that. Most patients with experience with Suboxone may be prescribed a 1-week supply, and they are requested to come back in a week so we can reassess. Many of our patients come weekly for about 8 weeks, and at that time we're connecting them with primary medical care. We're providing them individual mental health sessions, psychiatry, any specialized care they need. We're doing baseline fasting blood work to check for diabetes and thyroid disease, and we assess each for hepatitis A, B, and C, and HIV. We have on-site support groups, new to recovery, and we have an intensive outpatient program to help them gain tools, keep them in recovery. Our patients are assisted to find temporary housing or placement in sober living homes. If uninsured, the financial counselor will assess the patient and screen them for Medicaid. And we are part of a network, treatment network in our community that we reach out and we touch them and they send patients to us. So we're not a standalone clinic. We are connected. At baseline, every patient gives us a urine drug screen and we do a breathalyzer. In this way, we can see if they're using any other substances and if they're adherent to their Suboxone. We assess their response to Suboxone and may alter the dose, and because we don't want them supplementing with any opiates. It's amazing to see the improvement in just a couple of weeks. Some of the comments patients have said to me at return visits: I feel normal again. I got a job. I got my driver's license back. I got an apartment. And the one that always puts tears in my eyes, I got my kids back. I'd like to say that every patient has a happy ending, but I would be lying to you. Relapse to opiate use is common. It can happen early. It can happen several years into recovery. We praise them when they return to us for care. So as I conclude my story, I would like to say that whether I'm caring for a patient with HIV, hepatitis, or an opiate addiction, I see them as someone's child, someone's grandchild, someone's sibling. I see a child of God. They were once little. They had birthdays, maybe played a sport or an instrument. And hopefully they were loved and cherished by someone. They may have realized when they were growing up that they felt an attraction to persons of the same sex, They may have felt they were born into the wrong body. They may have made one bad decision that has changed their life. I see humanity in every patient. I remind my coworkers frequently in the infectious disease clinic that we are doing God's work. I pray for my patients. I pray with my patients. And my patients tell me they are praying for me. I've had opportunity to develop lifelong relationships. I have some patients that I've been with for over 30 years, and they're still alive. I've had a wonderful nursing career just filled with love. Because I know, there for the grace of God, go I. I would like to end and just remind everyone that December 1st is coming up. December 1st is International World AIDS Day. It's a day when we recognize all those individuals who have passed away from HIV and AIDS. And we also acknowledge the ones alive today and who are fighting, of course, to stay alive. So I just ask, maybe on World AIDS Day, you say a little prayer. Maybe you know someone who's had HIV, living with HIV. Keep them in mind. Thank you.
I hope you can see why my sister is my hero for everything that she's done, and it has had its challenges. I mean, lots of tears through the years, but perseverance, absolute perseverance. I remember when I remember back when AIDS was first diagnosed, and the times that we lived in were scary. And I remember Jean saying, how her floor has changed and the patients that she treats, and I feared for her life. But she persisted. She kept going. And I'm so thankful that she did, because we were raised by the same parents. You might have noticed that. And that every person is a child of God and deserve to be loved and treated as a whole person. And that's been Jean's mission in life. Not my favorite story, but one of my favorite stories to tell about Jean was we were at Grace Lutheran Church in Somers Point. And that was the church we grew up in. And we were being ushers that day. And we were in high school. And to get up into the sanctuary, you had to go up all these stairs to get up there. And one of the older gentlemen in our congregation fell down the stairs. And I was like, what do we do? What do we do? And Jean immediately ran down the stairs. Jean's in high school. And began administering to this man. And I'm like, what do I do? What do I do? And so I went to the front of the church and announced to the church that this man had fallen down the stairs and needed some assistance, and people got up to go help him. And I thought, there we were, both of us set on the path of our lives. That she went to tend and care, and I went to make a church announcement. So, are any questions for Jean?
So, I'm sorry, the combined medication, you say one of them was naloxone? I always say it wrong.
Suboxone.
Okay, and what is that combination?
Suboxone is buprenorphine, which is the controlled dangerous substance. It is what displaces opiates in the brain, in the mu receptor. It can be prescribed for pain. We don't do that, but so that's the active drug, and with it is naloxone, which is a blocker. So patients that take Suboxone regularly, if they were to indulge and use heroin or even maybe some fentanyl, that's a whole other story, they're not going to overdose. So it protects them from overdose.
So naloxone is the thing that they advertise so you can right? Is that correct?
So, yeah, naltrexone, naloxone is Narcan, yes.
Okay.
Yes.
You were saying that was, I'm just curious, because you said that could send someone on heroin into withdrawal. And I was
Yeah,
like,
so somebody's actively using heroin, it's in their body, and if you give them this Suboxone, you could precipitate withdrawal.
okay.
So they're gonna feel really bad, they'll start immediately sweating, they're gonna have, nausea, you'll feel like they have diarrhea, they have goosebumps, and they're immediately going in a very quick withdrawal.
Okay. So, because my question is, since they keep pushing about using naloxone.
So it's co-formulated,
Okay,
and
so it's just the naloxone, you're fine, you're not gonna send.
exactly.
Thank you.
Well, the buprenorphine alone, if you give them just buprenorphine alone, but they're at risk for possible overdose.
Thank you.
You're welcome.
Now, what role does technology, like cell phones and stuff like that have on the youth with regard to your subject? This information is so easy to share now.
There's good information, but there's a lot of bad information out there too. Probably more bad information, misinformation is out there. But you're absolutely right, we've come so far. When I first became a nurse, everything was on paper, right? We didn't have electronic records. We had a patient chart, if the doctor had it, you're running after charts and stuff. Everything had to be written down. We had copy machines, but that's about it. But yeah, as time has gone on, we use those cell phones for reminders for patients if they need to take their medication. Certainly to let them know.
Also, they can acquire drugs easier now.
Absolutely, yes, absolutely. People can connect with their dealers or whatever, and get those substances. They can also have hookups, if they're looking heterosexual or homosexual, if they're looking for sexual partners, there's apps for that. I mean, it's amazing what there's apps for. So, and there's a lot of good information out there, but a lot of misinformation.
Well, my dear sister, I've enjoyed our weekend together.
Yeah.
It's come to an end, but
Yeah.
thank you so much for being here and talking about people who society shuns, and even to this day, it's tough to see that happen, it's really tough. But I remember when Jean started this whole journey, and she said she was going to stay on the floor until AIDS was cured.
Well, I'm sticking with, I really would like to be able to stick with this, I'm in the infectious disease clinic, obviously. I also work, how many hours? Now 8 hours in the substance use disorder clinic. I would like very much to be there when the AIDS cure, the HIV cure comes. I'd like to be able to be the one to administer, prescribe it to my patients. And hopefully we can all pray and it won't be that far off. Every day we're getting closer. I mean, HIV has never been easier to treat. I tell patients, new patients, this is easier for you to manage than diabetes and high blood pressure. Take this 1 pill a day. If you don't want a pill, I'll give you an injection. We have injections for HIV. We have injections for HIV prevention. So we've come really, really far. We have yet to have a cure, a functional cure like we have with hepatitis C. Yeah.
Thank you all for coming.
Thank you for staying.